Thank you very much and good morning from Germany, and thanks to the previous speakers for laying perfectly the ground for my presentation. I brought today a question for the audience and for this roundtable. If we had a new pandemic today, how should the response look like with respect to migration? I deliberately chose not to ask how would the response look like, because I am afraid that the answer would be that we would run into the same problems and into the same challenges and the same mistakes that we have been doing. So in order to answer this question, it's really important that we are clear and answer questions about how can we avoid repeating failures, which failures did we do, what were the failures, and how can we avoid repeating them. It's important to identify fallacies and misconceptions and to deconstruct them. And it's important to be aware of the fallbacks that we observed during this health emergency and this societal emergency and find ways to overcome them. Let me start with the failures. So what were the failures? We heard several aspects today, and one of the main failures were that migrants in the pandemic response were regarded as a singularity, like as something that is exceptional. Well, we need to take care of the general population first, and then we need to take care of the exceptions within the population, which are the particular vulnerable groups or particular specific groups, instead of going directly for a whole population response. As a consequence, the inclusion in the pandemic response came too late, it came too different, so a lot of aspects that were implemented for migrants came along with a framework or a dimension that is replicates othering or discrimination. So the approaches to contain or prevent COVID infections and transmissions in migrant populations widely differed from approaches that were applied to the general population, and the response came too fragmented, which means that the different sectors that take care or are involved in migration as a complex process were not coordinated and were not harmonized between the different sectors. Where we also failed was to monitor the pandemic burden and the consequences. We just heard a few examples from Kuwait, and there are of course several experiences in several countries, but at a large scale, many countries failed to monitor properly the infection risk, the consequences of infections with respect to hospitalization and deaths. So many countries failed to do the proper basic epidemiological homeworks that are the fundamental basics of health monitoring. There are, of course, countries who did better and countries who did worse, but at a wide scale, I think there were few exceptions only where everything worked well for both the general population and migrants. This also relates to issues related to access to testing, to treatment, or to vaccination. By the end of 2021, we have conducted a systematic review about the global literature, and we found only 7 papers that dealt with and reported stratified vaccination rates that allowed to say how big or small were the vaccination inequalities between general populations and migrant populations. Only 7 by the end of 2021, more than about 2 years after the start of the pandemic. So in conclusion, migrant data has been a blind spot in many systems. It has been collected in a haphazard way. If it was collected, it was patchy, of low quality, and sometimes it was even measured but not made public due to political reasons. There were also the unintended consequences of pandemic measures. So this was a problem certainly that we faced also for the general population, which is linked to a linear versus a systems thinking approach that we always or often face in public health responses. So we had unintended consequences of the pandemic measures that became obvious, but there were several that were actually known to the public health community, or at least anticipatable, but they were ignored politically or by decision makers due to agnostics, due to underlying othering or discrimination or racism, but also because there were different cost-benefit evaluations done informally, or cost-benefit decisions made to say that we can't do this, we are aware of the potential consequences, but we take this cost because it's only migrants affected. There were also unintended consequences that have been unknown and unanticipated, but they have certainly remained unmeasured. So for the next pandemic, they are yet still unknown. Let me give you a few examples, and I will rush a bit through these examples so that we have more time. So this is the evidence state in June 2020, about 6 months after the pandemic started, where we only have very few studies done on migrants. And of course, it's in a very early phase of the pandemic, you could say, but until June 2020, there had been abundance of publications and a rise in scientific evidence on a lot of aspects related to the virus, but we really failed to generate timely evidence on migrant groups, especially as a lot of the pandemic measures from the very beginning affected mobility and migration. So by the end of March 2020, large number of countries had implemented complete closures or partial closures of the world, and about 90% of the world's population lived in a country where restrictions on migration were imposed for non-nationals or for non-citizens. And of course, border closures, we just heard it in the previous examples, have consequences not only for production chains and remittances, but of course, it's about income and livelihood of individuals. It's about healthcare access of people in the absence of insurance. And it seriously affected the migration journeys of the large number of migrants, more than 200 million international migrants who were trapped in immobility or in transit. And this created an existential threat to precarious cross-border labor migrants, especially. To give a very illustrative example of the unintended consequences of pandemic measures that could have been anticipated is, for example, lockdown-induced migration. An example from India, where due to the imposures of lockdowns, a huge number of labor migrants started internal migration from the city centers to the rural areas, carrying the virus into the rural areas and having a completely unwanted effect of facilitating transmission instead of controlling transmissions. To give another example that came to no surprise to many people in public health, was that there are specific groups, given the nature of the virus, to be transmitted in crowded areas, that people who live in shared accommodation, in camps or in dormitories are at highest risk. So here we see statistics published early from Singapore, where labor migrants living in dormitories have the highest risk for transmission in high number of cases. And you see how the numbers rise across these 2 months. And it comes not to a surprise, but these are the anticipated areas where we had pre-existing vulnerabilities that were not taken into account properly in many countries into the response. Singapore is a good example because at least there was this monitoring and there were appropriate reactions taken as we proceeded. But there were several countries, also high-income countries, to which also Germany would count, that were not in the position to properly monitor the higher risks in vulnerable groups, in labor migrants, in precarious working and living conditions. Another area in population groups, migrant groups that face severe challenges, people living in camps at European borders or internally displaced people in protracted displacement contexts. And these were often faced the lockdown traps in refugee camps, where In situations where physical distancing was not possible and overcrowding was pre-existing, the imposed movement restrictions, which were often imposed as a so-called preventive measure, put inhabitants at higher risk. Combined with the service reductions and the pull out of NGOs, this severely affected access to healthcare, combined with stopping of resettlements by the agencies and governments, or by stopping the relocation of national camps to the cities or to remote areas of or to peripheries of the cities. This was counterproductive because the number of inhabitants was not basically reduced, but even sometimes increased if new refugees entered the country. So overall, these aspects were quite counterproductive, and we faced that as outbreak management. Lockdowns and mass quarantines were applied, where the whole camp is put in quarantine, and a phenomenon that is called chain quarantine. So as soon as new cases occurred, the quarantine was prolonged, so that many areas were put under long quarantine, as we have also heard in other countries, for example, for whole city regions, which were not refugees, but labor migrants. Linked to this brings me to the fallacies. So the fallacies linked to that is that the securitized response would be more effective than an inclusive response. And a very good example of this is that the idea or the belief that mass quarantine would be more effective than, for example, other approaches like early evacuation or inclusive responses, from which we now today know that they are more effective. Another fallacy is, for example, related to vaccine hesitancy, which came on later as being a widespread narrative, that this would be more prevalent among migrants. Whereas if we look at the literature and the evaluations, we find there are only few evaluations that look at this, see that, well, if there is language concordant information, then we have the similar level of vaccination readiness among migrants and non-migrants. And it's rather the language incompatibility of the systems that lead to the vaccine hesitancy. And in other areas that we feign as the main determinant for hesitancy, the lack of trust, low education, low socioeconomic status, and not necessarily migration status, which means that these determinants are the same that we would face among other parts of these populations, and where public health needs to find solutions and answers. To dive a bit deeper into the fallacies, very early on, there was a situation that gave us an indication that mass quarantine cannot be a good answer in whatever context. Very early on, there were evaluations here published by colleagues in Sweden and Heidelberg from the outbreaks on cruise ships. And these modeling studies actually found out that to manage the outbreaks effectively, early evacuation reduces the number of incident infections as opposed to mass quarantine of the whole ship. Well, applying this situation to Germany or to other refugee camps would have been very beneficial, because when the early cases approached, and for example here in Germany in mid and March, the approach was highly securitized. So we had police forces building up fences, deploying helicopters and dogs to control people and to ensure that no one leaves the camps. And these interventions were not only found for the very first cases, but we observed them until the very late phases of the pandemic, until the end of 2021, and even in 2022, these were sometimes or often employed. We did a systematic review of the management strategies in light of precarious data. And we found that in the very early phases until end of June 2020, the attack rates in asylum centers were about 13% in German refugee camps. We had more than 100 centers with outbreaks, but in more than 75% of cases or outbreaks, there was mass quarantine deployed as containment strategy. Comparing the incidence risks, we found that those centers applying mass quarantine compared to conventional management approaches, which include testing or isolation and evacuation, the risk and the attack rates were increased by 56%. And the existing guidelines from the National Public Health Institutes or from the European Center for Disease Control in Europe were not always implemented. So the conclusion is that definitely mass quarantine is not only normatively a big problem, but it's also epidemiologically and from a public health perspective counterproductive. There were also several fallbacks. So the pandemic brought about a plethora of instruments that violate and harm individual and human rights. I mentioned mass quarantine and chain quarantine. We faced labor quarantine, where labor migrants were only allowed to go to their workplace and not allowed to leave the dormitories or the place where they were accommodated, except for going to work. We have the situation of preventive or preemptive quarantine, where people, new arrivals, are put under quarantine for varying time frames without or with limited or with no evidence that this is effective. We face situations of unlawful suspension of international law and right to asylum when countries at European borders did not allow any more ships to enter with migrants. We faced, and there is documentation of administrative pushbacks. That means where people seeking international protection are pushed back across European borders to other countries on grounds of presumed invalid COVID-19 test results, certificates, etc. And there are documented cases of unlawful detention where people have been detained for different time frames on COVID-19 grounds without proper legal grounds. There are also, to put it in a positive terms, several breakthroughs that we faced during the pandemic. There were some European countries that established the right to COVID-19 vaccination and treatment for undocumented migrants who otherwise would actually have had faced restrictions in that systems for other types of care. We had several countries and situations where the suspension of encampment was temporarily suspended, so people who have been living in camps were not forced anymore to live in camps, and other forms of housing were provided. We had outreach community models for prevention and control, where proper interpreting services were embedded as integrative part of public health services. And there have been situations and improvements in monitoring systems, or at least a political will to move forward and improve these situations. So what's the way forward? In order to address, to improve the pandemic responses, the challenges are, how can we avoid repeating these failures? How can we really deconstruct the existing fallacies of securitization? And how can we overcome the fallbacks linked to the increasing restrictions and this increasing othering of migrants? So in order to avoid these failures and as a basis for discussion, we need an inclusive response by default and not as an exception. We need to enhance our health monitoring systems, and we need to reduce the pre-existing systemic vulnerabilities, that is, all the known hazards from the decades of public health research about unhealthy living environments that can be found, for example, in camps, that can be linked to the lack of social protection and exploitation. We need to deconstruct the fallacies that securitization is a better response and implement the evidence into public health practice and disease prevention and control, which is important because despite the misconception that it's often the authorities that would implement the measures, we made the experience that it's also often public health services, not immigration authorities, that favor securitized responses. So guidelines are important, but they are not sufficient to change practice. We need other approaches here. And we need also cross-sectoral approaches where we bridge the health and migration ecosystems that operate in completely different normative standpoints and completely different logics of their systems. In order to overcome the fallbacks, and this is probably the biggest challenge, we need to counter othering, discrimination, structural racism, and the rise of nationalism and right-wing extremism also that we face in several areas of the world, including Europe. And we also need to capitalize on the, unfortunately only few, but nevertheless capitalize on these few breakthroughs and advance the agenda of inclusive health systems. With this, I thank you for your attention and I look forward to the discussion.